Welcome, everyone. We are back again and restarting our G&T podcast. As you can see, there's a lot of more people here involved now. Before we used to be me and Ghana. Now we have three more people in our team, which we're going to let them introduce themselves one by one. And then we're going to jump in and talk about it, GLP-1s in general. And then we're going to talk about good things, bad things, and so forth. Ghana, go ahead, start with yourself a little bit, real quick, and then the other three can present themselves.
Yeah, I'm Dr. Mohammed Ghanem. Most of you guys have known me from previously also with the G&T podcast with Dr. T. I'm so excited that we're renewing this. What's interesting is that it's still going to be a G&T podcast because you have Galvao and Ghanem, that's the G, and Tashira and Takla, that's the T. We can add something for Dr. Kitten also afterwards.
The K portion
The
somewhere.
K,
Yeah,
exactly, somewhere. We'll figure that part
GNTK
out later.
podcast. Yeah.
Yeah.
GNTK podcast, exactly. But yeah, I've been here with Orlando Health for 5 years now. It's actually going to be coming up 5 years by this July. Excited to be here.
Henny.
All right, I'm bariatric abdominal wall surgery. I joined the group here about 7 months ago now, and I'm happy to be here. I've been in practice about 9.5 years. I was in the Northeast for a long time, and those guys recruited me for here, and I'm very, very happy and excited to be here.
Galvão.
Hi guys, Manuel Galvão Neto here. I joined the group now. It's about 1.5 years, and I'm doing the bariatric endoscopy and bariatric research. And happy to be among you guys. And let's go.
Kittner.
Yeah, guys. So excited to be here with you guys. Happy to add the K to this podcast. So I've been with Orlando Health since 2022. I joined Dr. T and Dr. G 1.5 years ago. I'm leading the obesity medicine team. We are kind of doing very nice things and quite excited to be on this podcast. So let's make it happen.
Yeah. One interesting thing about Dr. Kittner is that he's also known as the elusive snow leopard because he's working all the time, but other than that, you don't see him anymore. So it was a great opportunity to have him here today off of work hours.
He kind of shows in for a couple of minutes and then disappears for 3 months and then shows again. That's how it usually goes. So, this has been a long dream and my and Gunner's dream to put everybody together. Then initially we started putting one piece at a time. Now we have the team pretty much complete. Maybe in the future we will add more people when the time is come. But right now, this is where we are. And we all together we will treat obesity as the chronic disease that it is with all the other medical issues. As like Henny said, Dr. Takla said, he also does a lot of abdominal wall reconstructions, which is based on a lot of obese patients that have hernias. They're not candidates for surgery, so he'll fix that. He's pretty well known on that perspective. And Dr. Kittner, super well known also for the obesity perspective. And another thing that he's super well known is for the geriatric, meaning elderly patients. So he's also super well known for taking care of these patients. And then Galvão itself, by its name alone, is one of the giants of bariatric endoscopy. And me and Gunn are just two surgeons trying to help.
You humble servants.
But today we will talk we're going to talk about the GLP-1s. Like it's been 2 years now, more or less, that GLP-1s have been in the market, officially or unofficially. Outside the United States, it's been longer. So we saw that trend way, way before it hit the United States. So that trend of people taking GLP-1s and help with weight loss has been around for many, many years, especially with endoscopic procedures. People are already doing that in the past. So we already knew that it's going to be a circle, right? You're going to have a lower patients taking general surgery or having bariatric surgery, but in the long run, they will come back because the medications, they work, they're fantastic, as we're going to discuss this, but it's not something that you can continue taking for life, right? It's another tool to put you back on track, just like the bariatric surgery. You have to make the lifestyle changes. You have to make everything else count, right? So let's open the forum. Maybe we can start with Ghana and go Hanny, Keitner, and Galvão. We can kind of talk as we go. Give it the pros and cons you guys think. Personally, I love GLP-1s. I think it's amazing what you're doing. It's not for every patient. I think it's more for lower BMIs. The higher BMI patients, 40 and above, I think gives them a sense of hope, but in the end, they don't deliver what they want to be delivering. These patients end up taking those medications 1 year, 2 years, 3 years without really having the full benefit from it and having more issues, the complications than anything else. So that's my kind of take. We should discuss that too. Gonna go for it. Tell me what you think.
Yeah, I think like you mentioned, it's been in the, it's been hitting the market for almost 2 years now that it's become mainstream. And it's really showing what we kind of expected it to see. So what we saw is that those patients who had lower BMIs, who had the right metabolism for it, were actually benefiting, and those did great, and they're doing still great with it too. It also showed that, look, what you kind of touched upon, Dr. T, is that when those who have high BMIs, BMI above 50 or above 40 in general, and a lot of metabolic issues too, don't really do as well with it, and they kind of wasted 2 years a little bit with that, and sometimes they've gained some trouble on the way too, because GLP-1s, while they're a great medication, and there indeed are, they, just like any other medication, they have side effects too. And this is true to any
Mhm.
medication. So some of them got some issues with reflux, gastroparesis, other problems as well. And what we saw also is that those patients who insisted to take them on, and I understand that if I were a patient too, I would be weary into jumping into surgery at first if I didn't know all the details. I would want to get that hope a little bit of, oh, a medication that might work as well. But they're really coming back and realizing that, like we kind of advised them beforehand, that it would probably not going to be that amazing change if you have a high BMI. Too. The other thing that you guys are probably reading on the news too, some other side effects are popping up on the news as well. And again, this is to be expected, just like any other medication. Not to say that there are not good medications. There have been reports of blindness lately as well. And this is why we don't recommend taking GLP-1s if you have diabetes that is affecting your eyes already. And there's also been reports of muscle loss as well that come with it too, and something to be aware of too. So all in all, good medication. We still don't have a lot of information on who's going to do great with it and who's not. We see patients that come in and tell me I started it and I did great, and I'm going to continue doing phenomenal, and others that gain 10 pounds on GLP-1s, and we don't have that information yet.
So again, let's ask Kittner, what do you think about what Ghana was saying about a lot of these issues that patients I have? By now, because we talked this before, you've been seeing a lot of success, not just people that did not have bariatric surgery, but also people that already have bariatric surgery to put back on track. So let's talk about also the good stuff that you see with it, please.
Yeah, so first of all, I definitely agree with you guys that for the patients in the highest BMIs, like the ones over 45, 50, it's very, very, very difficult to achieve successful weight loss just with these medications, the ones we have right now. What I see is that we have patients that not feel themselves ready for more invasive procedures, and they want to kind of give themselves a chance to achieve something meaningful, even though we know from a practical standpoint, most times they won't achieve that. It's pretty much the same that they used to do with the balloons in the past, like as a bridge for a major procedure. So this is something I've been seeing. They are kind of, okay, just give me a couple of months, let me see what happens with the medication, and then I'm going to feel myself ready for a major procedure. And sometimes it works well. If we cannot convince them that going with a more invasive procedure, either surgery or a bariatric endoscopic procedure, is the way to go. So this is the first thing. Then we have been discussing a lot what to do long term with these patients with the lowest BMI yet obese patients. and if the medication, thinking about the long term, is the way to go. We have, I think a couple of months ago, American Diabetes Association, they released a statement in which they say that if patients are taking the medication and they feel like they're going to lose weight, control their diabetes, and then get rid of the medication, this is not the way to go. So we need to have these patients on the medication beyond the time in which they're going to reach weight loss. Of course, we don't know exactly what's going to happen in 10, 15, 20 years. As Dr. Ganning just said, there are a couple of side effects of potential complications associated with the medications that are just being disclosed. And we expect that much more will be disclosed over the next few years. We don't know exactly what's going to happen in 10, 20, 15. We know that for the procedures, the bariatric procedures, they've been used for like a couple of decades, 15, 20, 25 years. So we know a little bit more about them long term than we know about the medications.
So I just saw this like early this morning. You know, the CEO of the company that makes, I'm gonna say the name of the company that makes Ozempic, right? Um, so he just got fired. That's what I read, because 50% of the sales from Ozempic dropped. Right? It's interesting, right? So
Yeah.
that big wave up of everybody taking it, and then now we started seeing this drop, right? Because people are seeing this is not sustainable, right? When you look at patients that are taking medications for a long time, they about 67% of them.
The drop on that brand that you name it was not just because patients not using, it's because there's new
Better medication.
medication. So don't jump on that fast, my
No,
friend.
I'm not jumping. I'm just saying, right? There are
Yeah,
people that
Yeah.
also there's a drop on that
yeah.
because
I'm
you
paying them
are
also.
67% of the patients tend not to take those medication past 2 years, and that is their own data. That's their data, right? It's not anybody else's data.
But there are confounding factors on your assumption. The confounding factors is that new and better medications, and the competition is fierce.
Yeah. I mean, if I can just,
Inevitably, you're going to get better medication as they go. But I think we have to remember that it's a disease at the end of the day. And what to Dr. T's point, I think he's, long term, I think there's not going to be a cure. There's going to be yet, as we know of. Maybe there will be soon, but it's going to be a treatment rather than a cure. It's not going to go away completely. You're going to have to continue. So, what Dr. Kittner was mentioning beforehand, thinking, oh, I'm going to take it for a year and then train myself and get myself back on track, that just does not work. There is no training. We say this all the time, that obesity is not your fault as a patient. It's not because you're bad behavior, but rather you have that predisposition. And as a matter of fact, just based on that, you're not going to train somebody also to do something different with time after they stop the medication.
yeah, and we are always stressing out that either medication or procedures, they are not shortcuts. We need to still stress out to patients that lifestyle changes, they are key. If they're not going through that and just looking for a shortcut, we know that long term, they are not going to be successful. All our successful patients, they adhere to lifestyle changes. So this is key. And just to complete what Dr. T asked me about with regards to the long-term complications. So we are talking about the muscle loss. And my take on that is, again, if patients, they are not working out, if they are not eating the appropriate amount of protein while they are losing weight, regardless of the strategy they are using to lose weight, surgery or non-surgical approaches, they are going to lose a ton of muscle mass. This is something that we cannot prevent if patients are not doing their part on the job. So this is something we need to have everyone hands-on. Otherwise, we are not being successful.
Mhm. And speaking of the benefits of GLP-1s, Dr. Takla, how often do you see somebody with a hernia that also needs to lose a little bit weight? Maybe the hernia is too big and has a lot of bowel in it that you can't even do the surgery, that you say, I'm going to use the medication, to help you lose weight to bridge you to have that hernia repair. Do you ever do that? Have you seen that often?
Yeah, it's actually quite often because I think I mean the main issue where people develop hernias in general is you know, having either surgery before, or they had weak areas like, you know, belly button hernias or groin hernias, but they've also been overweight, and that increases the chances of the hernia getting bigger over time. So they're symptomatic now and things like that. So I see quite often patients that are their BMIs are like, you know, 39 or 40 or 41. These patients, like once their BMI gets above 40, then kind of the risk of recurrence of a hernia is very high. It's actually about 40% or 50% if you repair it, no matter what modality you use for repair. So we tell them if we're able to just get you down below that, that's just kind of the mechanics of the abdominal wall. So there's a lot of patients that would be at that borderline, like where they're like 40 or 41 BMI, 42 BMI, and they're not interested in doing anything else. So those patients would be good for that. But then we get a commitment from them about like what Dr. Kittner said, lifestyle modification. Because if they, let's say we get them on a GLP-1, get their BMI to 39, do their hernia repair, and then 2 years later they sort of, their BMI now is 50, then their hernia might actually recur. So it's important to have that conversation with them, is that it's not just about like getting them through the hernia repair, but also long term they have to kind of maintain that weight loss somehow with lifestyle modification in addition to the GLP-1s. But overall, I think I agree with you guys. I think, I mean, the GLP-1s are a game changer. And I think my point of view on them is I think it's going to be, they're going to even get better and better. But I think at the end of the day, as you mentioned, obesity is a chronic disease. And my view on it for the future is going to be multimodal treatment. It's going to be medications and surgery and endoscopy and a combination of the three, or one before the other or one after the other. It's never going to be one thing that will maintain that weight loss long term.
That's why. That's why Dr. Packard, we always had when these groups started. Used to be one surgeon, they became two surgeons. It was always about surgery, in nutrition, right, and psych, and that's it. And as we grew, the vision was always to make this a multi-modality, multi-pillar treatment group, right? So it's so important for us to have the obesity medicine, the surgical arm, the endoscopy arm, the mental arm, right? The nutrition arm, right? And then we are also trying to incorporate the exercise coaching type, lifestyle coaching arm too, which is a little bit more tricky, but we're working on that. And then you have multiple surgeons too, multiple proceduralists that have a different view of things, right? So then we can always bounce ideas and discuss ideas in between cases too, right? Like complications, issues that we see coming to us, even issues based on chronic taking of GLP-1s. We can always discuss things like that. Galvão, from your end, from the endoscopy side, where a lot of data originally came from, or a lot of outcomes came from using medications and endoscopic procedures. What's your thought for the future, and right now, what's going on that side?
Well, Chi, thank you. We begin. Why we begin at the first using medications for us? Because we need it as endoscopy. Because endoscopy don't have the power of surgery in terms of weight loss and maintenance of weight loss. So we needed to stand that reach. So we start with balloons, and the first thing that we were the very first to publish on that is that at the moment you remove the balloon, and at the moment you remove the drug, the patients tend to rebound. And let me just show to you, I'm here open X this yesterday, and it's trending now in X from Dr. Michael Albert. So let me put my glasses here. So that's is a new Oxford meta-analysis that was presented in European Association of Surgery of Obesity in 2025 this year, confirms that many of us had observed. Stopping GLP-1 often leads to rapid, near complete weight regain in 1 to 2 years. We just discussed that, okay? Let me give you data, meta-analysis on that. Key findings, around 8 kgs with all GLP-1s considered, 16 kgs with the newer ones, semaglutide and tirzepatide. Weight regain after stopping, 0.7 to 0.8 kgs per month, 8.3 to 9.6 regain after first year. Full return to the baseline, less than 1 year, 0.9 year on the older GLP-1s, and 1.7 years, around 2 years on the newer GLP-1s. So it means that if you stop the drugs in around 2 years, you're gonna go to the baseline again. The same with us. If you like an endoscopic balloon that have to stay for 6 months to 1 year, once we remove, they regain back, and we already know that. We didn't need it. So the drugs are the same, because obesity is a chronic progressive disease, and I agree with Gannon. Doesn't matter what you do, you stop it, it comes back because the disease is there. There's no cure for obesity right now. So we start doing that OT, the young T and OT. And it was very successful. So we could exchange the range of our reach for 2-3 years on that direction by adding the old GLP-1s at the moment we remove the balloons. Then, as we are developing endoscopic suturing, it lasts 3 to 4 years or whatever, and we wanted to get the same amount of weight loss of surgery, at least the sleeve gastrectomy, that is the entrance bariatric procedure. So we begin with the newer GLP-1 analogs, and guess what? We are getting there. So instead of our 15, 17% total body weight loss, even 20, we are getting 24, 25, 28%. So to us in bariatric endoscopy, GLP-1s are really, really a blessing in terms of to the patients that want more standing on that direction. And we just presented last year in American Society of Bariatric Surgery the first 1,000 cases we did in Asia, in India, does work as well, for 5 years, and 16% total body weight loss, and most of them in some sort of drug combination. So for us, it's a good scenario. That said, before I close, I wanted to state that GLP-1 analogs that come by chance, it comes from a lizard, it's called Gila monster. It lives in the desert here in the border of Mexico and United States, was biting some people was dying. And when they start biting officers, United States decide to research that. And they researched that they was once thought that was poison, is the GLP-1 that they produce, and those people are dying by hypoglycemia. So that's all the research start. And we have now a drug that for the first time on the history of mankind is treating obesity, and it opened up to us such a wonderful world that we can clearly control the disease, and in 3 or 4 years we clearly will understand which position each one of us will have on that algorithm.
So basically, just to kind of the medication you have to take for a long time. If you don't take it, you're going to have weight regain, just like what you said with the data. But what it did was, to me, and I think for the group, I think we all think alike, is it brought shine a lot of light into a chronic disease that does not have cure. It's a chronic disease that requires you to completely make your changes nonstop. So with that said, Kitner, can we walk us a little bit your train of thought in terms of, in 1 minute, 1.5 minutes, something quick, when you decide the patient has been on GLP-1, you say, okay, guys, maybe it's time to think about surgery or endoscopy or any type of procedure.
Yeah, I would say that every time I see a patient, the first thing is this just a patient with obesity without major metabolic complications, or this patient has also metabolic complications? If the patient does not have metabolic complications, so the leading of those metabolic complications is diabetes. Of course, we have several others, but let's say the patient has just obesity as a chronic condition, but no other major metabolic complications. So if this patient has a BMI above 35, during my first approach, I'll try to walk the patient through the various possibilities that we have, including surgical and non-surgical strategies. and try to figure out what is the familiarity of the patient with that. Does the patient need a little bit more teaching on that or not? And then depending on patient thoughts, if the patient is open to something more objective, meaning the surgery, we know that the results are going to be much more long lasting. We know that patients are going to notice the benefit much sooner. So if they are open to a potential surgical procedure, we are going to go, we are going to start digging a little bit more deeper on that route. If not, we are going to definitely start discussing about the benefits, the pros, the cons of being on a GLP-1 medication, and then go from there. If the patient has metabolic complications, I'm going to go even a little bit lower on the BMI, in which I will approach the patient with the possibility of a procedure, just because there are so many different benefits the patients can take from that, that I'm going to open up this window a little bit sooner for the patient. But then again, we have those patients that, regardless of their BMI and metabolic complications, they have their minds completely closed to anything a little bit more invasive. And then we are going to just make sure they understand, again, there are no shortcuts. They're going to be on the medication, and this is potentially lifelong therapy. And if they have a very high BMI with the metabolic complications, I don't expect at all any kind of cure, and maybe a partial control. From the very beginning, I'll tell them I don't expect that someone with the BMI of 50 will come to a BMI of like 28 or 30 just with medications plus lifestyle changes. This can happen, but it's just unusual that I do not provide patients with any false hopes. So I'm going to definitely go straight to the point.
Okay.
If they are much more borderline, then we can occasionally get there, but again, they are going to be on the medication as lifelong therapy. As we have extensively mentioned here, if they stop taking medication, and this is my everyday experience, they are going to regain weight very quickly. And I mean, the numbers that Dr. Galvão showed that were just published, my own experience is that it's even faster than that. Patients regain weight very, very, very rapidly. Sometimes I do not see the patient for 3 months, and then he regained like 10, 20, 30% of their previous weight in the first 2 or 3 months. And I'm like, what happened? And the patient was like, I was not able to afford the medication. Insurance just is not covering that anymore, or something else happened, occasionally some side effect. And then, wow, everything is a mess. So we need to be very straight with patients and do not provide them with any false hopes, and then we can go from there.
Yeah, yeah. The
No,
other
no.
thing that, it is also Mental Health Awareness Month, as many of you know. And don't worry, Andre, I'm not going to challenge you with the ice bucket challenge. But that said, I want to ask Dr.
Wow.
Takla.
Just putting out there so everybody gets.
Exactly. Maybe we'll
If I
challenge
get
Dr.
challenged, you're getting
Takla, actually.
next.
Yeah. Hey, man, I don't mind it. After a workout, it cools me down,
No,
right?
no, 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 no. Before the workout.
At 5 a.m., right?
Yeah.
So, Dr. Takla, speaking of Mental Health Awareness Month, there has been a lot of talk about mood changes with GLP-1s. So can you talk to us a little bit more about that? Have you seen that, or any of you guys, have you guys seen that also with patients having a little bit of depression and or anxiety with GLP-1s, and what are your thoughts on that?
I don't know if you could blame it directly on the GLP-1, like as a substance or medication that causes that as a side effect. I'm not aware of that, but maybe it's out there. I'm not sure it's one of the side effects. I don't think so, but I think it's mostly like what people experience in terms of changes in general. Like, whether it's a side effect, meaning, delayed gastric emptying, their stomach doesn't empty as good, so they're nauseous, they don't feel great, so they're depressed. Like, why did I start this? Is it really going to do anything? And it's giving me that side effect. And early on, the patient experienced these side effects, and over time, usually it goes away. So early on, when someone starts something new and it's making some changes to their physiology, or that affects their mental health, because it's an additional either stress or something additional they think about throughout their day. So that's kind of part of it. The second part are the, like, what happens with any with bariatric surgery is like, the changes physically that happen when people lose weight, and that sort of changes a little bit about their self-esteem and how they think of themselves and their relationship with others and things like that. So I think that's kind of maybe what people are seeing for those two reasons. But I mean, overall, it's very important. I mean, we all know that with, from surgery, at least from the surgery arm, we know that, mental health is very important for patients that, are thinking about having weight loss surgery, and what is their, motive to pursue that, but then also after surgery and the changes that happen, because it provides a lot of anxiety, a lot of stress, and a lot of things at work that are different. Things may change. Maybe people that are working from home now, they're sort of like want to go out and, go to an office and work, and that's, affecting their work environment too, things like that. So.
Yeah, I mean, there have been some links to GLP-1s and depression per se. It's not quite clear yet. There's not really good studies to show it. There's also some changes in personality, as Dr. Takla mentioned, with just the weight loss. Your dynamic with others sometimes changes too, whether from surgery, like he mentioned too, or medication. So it's really not quite known yet. But it's important for you to know that if you're on those medications, you feel quite funny, you think you have symptoms of depression, very important that you seek medical help and talk to your provider about it before it gets out of control. And the other thing that we also do not recommend, that don't go wandering into the desert looking for a Gila monster to bite you so that you can lose some weight.
That's awesome.
What do we have against the desert and the poor lizard? They're cute. Just don't let them bite you.
They actually are cute. If you Google an image of a Gila, Gila monster, they look pretty mesmerizing, actually.
They look what? Miserable, you said? Or cute?
Mesmerizing. They look cute. They have
Oh,
nice colors. They
mesmerizing.
look interesting. Yeah. Mhm.
So, guys, final thoughts. Before we regroup next time for another topic, any final thoughts? Galvão, any final thoughts there?
Yeah, I do. I think that we're gonna see in the near future a rearrangement of the algorithm of which treatment we have to offer to each step of the way of obesity, as we saw before, like 15 years ago, with the cardiovascular disease pipeline. So you have behavior modification, you have drugs, you have the fantastic revolutionary endovascular treatment that become then the mainstream. And even the open heart surgery, as we saw, that was down like a lot, now is up. But you were performing those open heart surgery in more sicker patients, because where the preventive and minimally invasive approach didn't work, we're gonna see this. I've seen in my vision, we're gonna see the same rearrangement in the obesity. This is the most prevalent disease of mankind. Half of the population of US still have obesity, and I think that GLP-1 is going to have an impact on that. They're going to put a dent, lowering on that. That's very, very good for the very first time. And then there's rearrangement of what we're going to have to do and wherever. And you're going to see that professional like Dr. Kittner, they will go up front and taking the lead of this and saying what we're going to do first or not. And that will be a rearrangement, but prepare to do more and more and more procedures, because more and more people will be treated by obesity. So they're gonna get in the pipeline. At the end, it's gonna have outputs on each part of the disease step or phase.
Hittner, from the obesity specialist, and which is the front runner. It's very interesting, right? Things change a little bit. The front runner now on care and pretty much deciding when is the time or not. From you and your final thoughts.
Yeah, I'm totally in line with what you guys said. This is multimodal. It's turning out to be much more multimodal than it was before. Again, with all that Dr. Galvão said, we just need to figure out who will start with endoscopy and then medication, and then surgery, and then medication, surgery, and maybe endoscopy at some point. So we just need to find and tailor this treatment appropriately to the right guy. But as a group, I'm quite happy that we have everything handy right now. We are just moving towards new directions and getting stronger and being able to get any single patient since the very simplest treatment until the more very sophisticated and complicated one. So we are there.
Henny, from your end, any final thoughts?
Yeah, I think a couple of things. I think I agree with you guys. I think it's going to be like kind of a different algorithm for treating obesity as a disease and how other surgical diseases interact with it. But I think there's two things. One, advice for people that are looking for treatment, regardless of what modality it is to try to figure out, the person that they're seeing. They got to present to them all of the options that are available. Like Dr. Kittner mentioned, they have to be aware of kind of all of it so that they can get them to the right place when they need it, whether they've had side effects from medication or failed medical therapy and need to go to surgery or whatever it is, or need a revision, for example, after having weight loss surgery in the past. And then the second thing I think that's going to have a big role in the future is genetics and AI. So genetics is going to be basically determining what patients where does that patient fit in the algorithm genetically, and also by the help of AI, where you input the patient information, their genetic testing, and you say, hey, this patient needs this.
Ghanem.
Yeah, I think, as a patient, what my advice would be to you, be curious. Be curious, talk to your provider. If you're going into medications, ask your provider, well, what do you think about surgery? Would I qualify? Would I not qualify? It doesn't mean that you have to go that route. Just be curious about it. If you're going in for surgery, ask about medications. Say, talk to your provider and say, would you think that would help? Would that think, that would help before or after? So keep an open mind and see what your options are, and make sure you choose the provider that can talk to you about both and gives you all the options and lays them out, and then can make the advice for you as well, but later on, but make sure that they know about both.
So I agree with all of you guys, and this has been a great episode. Just to kind of close the whole thing, and yeah, we're working on, hopefully together, as you can see here, with also nutrition, psych, and so forth, to develop a very robust protocol, because the medications ain't going nowhere. They are part of the treatment. And it's a multimodality, just like cancer therapy. You have to have multimodality therapy for this chronic disease to be able to sustain long-term outcome, meaning success, right? So with that, we end the episode today, and hopefully we catch you up with the next one, which you should be recording soon. Bye.